All right, I came into the field more by default than by intent. I went for vocational counseling, such as it was in those days, around about 1959. There was a group in the middle of town that did vocational counseling, and they said I should do law because I had a well-developed vocabulary and used words reasonably well. So I enrolled at Wits. One of my first year subjects was psychology, and part of psychology was neuropsychology. So I went on with psycho and then did an honours in neuropsychology. In the third year of psychology, we had to do a research project in inverted commas. We'd heard, there were about 3 of us involved, of the NIPR and of the neuropsychology division. So I spoke to Nelson, the head, and he said, yeah, he'd be happy to cooperate. So that was how I had my contact with the NIPR. We did the project, which involved alcohol, as a lot of the early work did at the NIPR. I think basically it was to look at changes in EEG frequency as the amount of alcohol that you imbibed increased. And of course, being students, this is right up our alley. And then when I finished my honours degree, I applied for a job at the NIPR. At that time, the only posts vacant were in what was called applied social psychology and in Skeefer's section, stats. I stuck it out for a year and then went to see Dev Chisel, who was second in command at the neuropsychology division. He said that I could have a job, and so at the end of that year, which was 65, I transferred to neuropsychology division. So from 66 to 93, I worked in the neuropsychology. The one thing I do remember was being called upon at ungodly hours by Nelson and Dev Chisel to accompany them to record heat stroke patients for the mines. The mines were approaching the depths which pushed the temperature very high, and a lot of miners suffered from heat stroke in the early days. And there was a theory that doing EEGs on them would predict would be prognostic. But of course you had to drive out to Welkom and to fairly far-flung areas. So I was recruited to do this, with Dev usually, to do the donkey work really, attach electrodes and help with recording. Other things that I was involved in the early days was to record clinical EEGs The NIPR had quite a busy clinical EEG section or service for doctors, usually neurologists, who didn't have their own recording facilities. So we recorded EEGs for, say, 50–60% of the neurologists in Joburg. There was a strong connection between the NIPR EEG section and the Princess Nursing Home and also the Johannesburg Hospital. Through this kind of work, we got into training EEG technicians because there was no other establishment which had any kind of training facility. This is recognized by the Medical and Dental Council for registration purposes. And we trained, in the early days, possibly 90% of the EEG technicians, and they came to us from all parts of the Republic. Basically, the course involved 3 weeks of lectures. Then the impending EEG technician, or intending EEG technician, would go back to his or her practice, do recording, and then we would monitor them. They would post them to us. We would check for quality, and if after a year it looked reasonable, there would be a practical exam. There were research projects at that time, nothing really spectacular. I had my accident in 1967. This was just after we had been down to the Cape and recorded EEGs from applicants for submarine service, the original Daphne cruise. Obviously, being a submariner, it would be undesirable to have epileptic seizures. And the idea was to try and exclude this type of person from submarine service. Because of various staff shortages in other divisions, I didn't do any EEG recording, but did interviewing of some of the candidates. Later on, after my accident, I obviously couldn't come down to the Cape. So I got into analysing EEGs and analysed most of the early submarine crews. And then it also got into the divers. Obviously a diver who has an epileptic seizure underwater is in great danger. The EEG is not a very good predictor, well, not 100% predictor of epilepsy, but it does give you an indication of possible seizure. The other military aspect that the division was involved with was the selection of pilots. And again, you don't want to pilot with epilepsy flying your aeroplane, especially if you're a passenger in the aeroplane. So the idea was to try and exclude people with suspicious EEG activity from applying for pilot jobs. I think probably that was quite a useful application of the EEG. I don't recall any people that we selected flying an aeroplane into the ground, possibly because of the seizure. Nelson became assistant director of the NRPI in around 76, and they made me head of the division after a few years. And I was head for until 93, when the whole Bang shoot was closed down. We kept our clinical program going, and we got into training not only of technicians, but also of neurology registrars, again from the Joburg Hospital. So at one stage, I think every neurologist in Joburg who had any interest in epilepsy, and therefore the EEG, had been trained by us. And I found that a very rewarding part of working in the neuropsychology section, because the people, the neurology registrar, or baby neurologists as they were referred to, were bright, very keen to learn, and often grasped what you taught them within a couple of weeks. It was also interesting because they would refer difficult cases to the NRPR for a second opinion. So it was interesting to get patterns which had flummoxed the neurologist. Why did I become interested in neuropsychology? Well, it sounded good, it sounded relevant. What could be more important or significant than trying to correlate what happens in the brain with what eventually emerges as a person's behavior? And in those days, very little had been done, particularly in South Africa. So it sounded a good field, an interesting field, and a novel field to get into. And that's basically why it happened. Possibly the research I was most involved in was on the effects of maternal antenatal decompression on the development of first the fetus and then the baby. The concept was initiated and applied by the professor of obstetrics and gynecology at Wits Medical School, someone called Haynes. And his theory was, from anecdotal evidence, that the quality of the baby after the mother had been decompressed, which sounds slightly obscene, was much better than mothers who hadn't undergone the procedure. Basically, the idea was to put an airtight cover over the mother's abdomen and then to evacuate the air from the cover by means of a vacuum cleaner. So the sales of Hoovers and other makes went up quite significantly while the theory was at its peak. This was done intermittently at first, at various stages of the fetus's development, and objective testing obviously was needed. So we were involved in a double-blind study of the effects of decompression. The investigator and the mother were kept unaware of whether they were receiving antenatal decompression or whether it was just a sham pump. Anyway, it turned out that there was no difference on objective testing of the abilities of children after the mother had undergone this sort of treatment. And it faded pretty rapidly from the medical repertoire. I did my MA on this project, and at some very later stage, probably after about 10 years, another prominent gynecologist in Joburg, I won't mention his name, decided that there was some value still in antenatal decompression, and that the early work hadn't applied it long enough. So he recruited from his patients a number who came to us and underwent decompression for, I think, 3 months at the critical stage which he determined. Again, the effects were not measurable, and his wife used this for her thesis. The other aspect which I haven't really talked about was that the division of neuropsychology was in fact a true division of neuropsychology, which meant that it used various tests as objective indices of behavior, and also it could help in establishing the effects of brain damage, for example, on the extent that the person had suffered from a functional point of view. The first project, that I think, the first true neuropsychology project in South Africa was the study of the Knysna tree cutters, or lumberjacks, I suppose, because they underwent a range of tests, psychometric tests, tests of motor function, as well as EEGs. So later on this became more and more fashionable, using tests to measure the effects of brain damage, and the NIPR was very much involved in the early days. and again right to the end. There were various batteries of tests. Initially they were tests which were devised on an ad hoc basis. If you knew a patient had suffered damage to, say, the motor area, you would then concentrate on motor tests, for example, of tapping speed, of grip strength, and anything else which seems relevant to the specific case. I think the NIPR neuropsych division had quite an influence on the early days of neuropsychology, and quite a few psychologists from universities came to us for training. At a later stage, neuropsychology test batteries became commercially available, and we bought one of the first in the country and trained some academics in how to use it and what to use it for and how to impart what the battery did to their students. That particular battery is still used today. I think this is where the NIPR suffered a fatal closure, because there were definitely divisions which had a significant role even at the end of the term of life determined by the HSRC. And I think the neuropsychology division would have been useful from a training point of view for cross-cultural research, which is still today sorely needed, and also as a test distribution and test control center, which I don't think is looked at enough even at this stage. And I think we could have fulfilled that, all those three roles, without much trouble. There's a lot I would have liked to have done, but apparatus and equipment became exorbitantly expensive. Things like MRIs became relevant to the study of brain function, and also what do they call them? PEGs, I think, which measure the activity of certain areas of the brain during a particular task after injection of a radioactive substance. So that type of equipment would have been totally beyond our capabilities. The budget meant that people got very uptight every time we asked for just a straight EEG machine. So asking for a couple of million for an MRI, I think, could have caused several heart attacks. So I think the HSRC it certainly didn't fulfill its mandate by closing the NIPR neuropsych section. I think psychology has become an occupation rather than a calling, as it was in the old days. And people are out to use it to make money. Now, there's nothing wrong with that, except that I think some of the fees laid down these days are far too much for many people even with medical aid assistance. So go into the field, but I think also remember that there are people who need the services you can offer. You can't afford it, and make allowance for that in your patient repertoire.